We have to.
Oh, we've got to leave. Okay.
Yeah,
Okay.
because there's a class in there.
Gotcha. All right. Thanks.
Good afternoon, everyone. Welcome to the last research symposium of the quarter. So I hope you're all celebrating the end of term, almost, maybe next week. I'm just here to greet you, say hello, welcome you, and thank you for joining us. And I'm going to turn the introductions over to Wanda, who is Andrea's collaborator.
Thanks, Carol. It gives me great pleasure to introduce Professor Andrea Hartzler today. She's an associate professor in the Department of Biomedical Informatics and Medical Education here at UW. She got her PhD here at UW as well in biomedical and health informatics. And I've had the good luck to be a collaborator with her for a long time. She's the co-director of the Clinical Informatics and Patient-Centered Technologies program, which is jointly offered by the School of Nursing and the School of Medicine. And then she also co-chairs the UW Medicine Patient Tools and Engagement Committee. And she's an affiliate investigator at Kaiser Permanente Washington Health Research Institute. That's a long-winded one for me too. And she's also very well known for her work in patient-reported outcomes and lots of work in technologies to help support peer patients in helping each other. So I'll let Andrea go ahead and talk about this latest work.
Sure. Thanks so much. Can everybody hear me? Is working okay? Great. Well, thanks so much. I'm really excited to share our new grant that was just funded by the National Library of Medicine called UnBIASED, which stands for Understanding Biased Patient-Provider Interaction and Supporting Enhanced Discourse. And in this work, we're taking an approach called social signal processing, which I'm going to talk a little bit more about, to try to detect hidden bias in the interactions between patients and providers. And then we're going to be doing a human-centered design approach to design reflective feedback to patients and providers about that hidden bias in their interactions. This is work that I've got this wonderful team that I want to introduce, actually. Some of you are here today. Our team is just fantastic. We're collaborating in a two-site team with University of California, San Diego, with my collaborator, Nadir Weibel, who's with us through Zoom today, and his PhD student, Stephen Rick. They're going to be our computational team running the social signal processing component of our project from University of California, San Diego, and the computer science department. Up here at University of Washington, we're going to be leading the design of reflective feedback. All of you know Wanda, who just introduced me. Thank you so much. And Jana Sabin actually is a professor in my department, and her expertise is in implicit bias in healthcare. And I'm going to talk a little bit more about that. You've probably been hearing more and more about this in the news. And outside of healthcare as well, we're hearing more and more about implicit biases, which is the focus of our work. We've got a wonderful advisory board. I couldn't ask for a better team. I'm really excited to dig into this work. So again, this is a 5-year grant. We just got started about a month ago. So I'm going to be talking today more about kind of what is motivating our work, why we're focusing on hidden bias in healthcare, why it's such an important problem, and the innovative, unique approach that we're taking. As we get underway, I'll be talking a little bit about our prior work as well that's setting us up with some really solid grounding for this work. I wanted to start, though, by sharing a story about Carla, the quilter. Think about Carla. She's in her mid-30s, and she is an avid quilter. And her boyfriend actually is rushing her to the emergency room. She was handling a bowl at home, and she dropped that bowl, it shattered, and she's got this big gaping wound that goes from her palm all the way to her wrist. When her boyfriend drops her off with the emergency department resident, he expressed his concern that he wants to make sure that her quilting is not affected and that her fine motor control is looked after by that resident. The resident said, "No worries, let me just stitch her up real quickly, no problem." And there was actually a student, this was an academic medical center, and a student walked by and recognized Carla, who was also a professor at Yale. And when the ED doc got the resident, ED means emergency department, so the emergency department doc got wind of this, he said, "Oh, wait," he stopped in his tracks and said, "Oh, Carla, you're a professor at Yale?" And the next thing you know, Carla is rushed to the surgery department, and the best surgeon in Connecticut is rushed in to do an emergency surgery, and her hand was restored to pre-injury condition, which is wonderful for Carla. So let's step back and think about this story and what happened there. And what would happen if Carla was a Carl or had some other characteristics. This is an example of subtle discrimination that we talk about as implicit bias in healthcare. Carla, we know her as a quilter. We also know her as a professor. And so when Carla, the professor, was identified, this triggered a bias, which we call in-group favoritism. There's many different kinds of biases. This is one. And what that did was it qualified Carla, the quilter, to suddenly become a fellow member of the Yale faculty. And this qualified her for elite care. And so this is great for Carla because she's already advantaged, and it provided her with additional advantages. But if you flip and think about folks on the other side of that coin who are already at a disadvantage, this is perpetuating disparities in healthcare, which is a major problem. And actually, Tony Greenwald, who's a professor here at University of Washington, talks about these hidden biases, or what are known as implicit biases. More generally, he and his co-author wrote a book called Blind Spot to talk about these biases that we all actually have. Even if we don't intend to, we all carry them to more or less extent. And they're shaped by our cultural upbringing, by attitudes in society about race, age, gender, political views, all kinds of things. And you're probably hearing more and more about it in the news these days because it's surfacing, which I think is a good thing. And so folks have been looking outside of healthcare at these kinds of first impressions, or what we can think of as snap judgments. In a research study in 2006, participants were able to very quickly make first impressions about what is attractive, likable, trustworthy, competent, or even aggressive qualities in people. And in fact, what they did was they showed people faces, and in as little as 10 milliseconds, participants were able to make these kinds of assessments about people's traits in a reliable way in just 10 milliseconds. And those traits, those assessments were stable when they were reassessed. But people make these first impressions really quickly. These are snap judgments that we all make. It's human nature. And what's problematic in these snap judgments is they can carry these implicit or these unconscious biases that we all have. And we refer to these as hidden biases in our work. These are pervasive attitudes. Even if we don't want to have them, we carry them to some extent, even no matter how egalitarian we want to be. But they are measurable, and we can do something about them. And we think it's very important in healthcare to be looking at hidden healthcare biases, because these happen out in the world. They also happen in healthcare, and patients' experiences of discrimination are very problematic. So patients that feel discrimination based on these hidden biases are known in the literature to delay seeking treatment. They have lower trust in their healthcare providers. They have experienced increased stress when they encounter the healthcare system, and they also have poor continuity of care, meaning who they're seeing when they engage the healthcare system. They're not always seeing the same provider, so there's a lack of continuity of care. So this is a real problem, and in fact, there's a growing body of literature that illustrates these types of discriminations and how they are tied to health disparities, right? So differences in care that people receive based on stereotypes that are negative and prejudices. And in this book, or this report that's almost 20 years old now, that came out and was published by the Institute of Medicine, now known as the National Academies of Medicine. It's a big body in Washington, D.C., reported on the literature on these implicit biases. And they talked about how some biases are conscious and explicit, but more often they're unintentional, and they're implicit, they're unconscious, they're these snap judgments that people make. And this latter type of bias is what we're looking at addressing in our work. These kinds of prejudices and hidden biases contribute to health disparities, right? So folks that experience this kind of discrimination, have poor access to healthcare. They have poor trust in their healthcare providers. They experience poor quality care, and they also suffer from worse patient outcomes. So it's simply not fair, is what me and my team and a lot of us feel, and we want to do something about it. So let me give you a few examples of the kinds of things that, just simple examples of things in the literature. So for example, this paper talks about how Black patients are less likely than their white counterparts to be referred to treatment following heart attack. Black patients are undertreated for pain. This has been a very strong trend in the literature, multiple papers with this outcome. Black patients are more likely to have higher childbirth mortality than white patients. And this is after controlling for factors like income and education. These disparities really reflect racial differences, which is just not fair. It is not just based on race that we're seeing these hidden biases. We also see gender gaps. So women are less likely than men to be referred for cardiovascular testing. And there's also a number of other groups that experience these hidden biases and discriminations, such as folks from the LGBTQ plus community as well. So this is a major problem, and we're starting to see these hidden biases and prejudices show up in our technology as well. So about a month ago, there was a report about medical algorithms that are triaging or are trying to schedule appointments for patients based on the severity of how sick they are. And what they found was that white patients were having their care prioritized over sicker Black patients. And so maybe that's because the training data is just based on a higher proportion of white patients. Not sure, but our technology is starting to carry these implicit biases. So this is a major and growing problem. We've known from this IOM report that it's been a problem for 20 years, but it continues to be a major problem. So how can we address this? Most of the work that has looked at addressing hidden bias in healthcare uses training programs, so educational approaches. When a doctor is learning to become a healthcare provider, maybe they'll take courses, they'll learn from a book, maybe they'll do workshops. Jana Sabin, one of our collaborators in the back here, helped develop a module that is actually available through the University of Washington Medical Center on implicit bias, and it's an educational module that you do online. It's wonderful, and I would recommend it highly. These are great resources, these educational programs, but one of the problems is that they're disconnected from the practice of healthcare, where these kinds of hidden biases emerge. And so it can be difficult for someone to learn from a book how to communicate well in a patient-centered way that's empathic, and then carry that into the real world when they're interacting with a real patient. So other kinds of programs are simulations. So a standardized patient is an actor, and there's programs like the virtual patient assessment that allows residents who are doctors in training to interact online with different kinds of folks, people that look different from them, and practice their communication skills. There's also, if we step outside of healthcare, there's other kinds of technologies and support. One of them that we're looking at in our work is called the Implicit Association Test, or the IAT. And this is a test actually that was developed in part by Tony Greenwald and folks at Harvard at Project Implicit. And the goal of this is really to raise awareness and better understand implicit bias, these snap judgments that people make about others. How many of you are familiar with the IAT or have taken it? So several of you. There's actually, if you're interested, you can go to that website and you can actually test this out for yourself. I want to give an example of how this works. It actually relies on reaction time, so those quick snap judgments that we all make. And so a participant will come to the computer, and this is an example of a black-white race attitude test that compares pictures and words. So pictures of Black folks, pictures of white folks. Words that are good, words that are bad, or positive versus negative associations. There are many different IATs. This example is for race, but they have them for people that are looking at weight, looking at disability, looking at gender, all kinds. But this is one for race. In this example, the goal really is to be able to sort two categories of faces. So if you're shown, for example, a white face, you're asked to click the left button. But if you're shown a black face, you click the right button, right? So this is kind of a training that you're put through. Next, you're shown some positive words like happy, beauty, joy, and you're told to hit the left key when you see those words, those positive words, and then hit the right key, for example, if you see words that are negative like filth, greed, sick. And then the test begins. So for example, in this arrangement, a white face is paired with positive words, and the participants instructed, when you see that pairing, hit the left key. And then there is another pairing, such as a black face with those negative words, hit the right key. And for some people that favor white race over black, they'll fly through this very quickly. There's other arrangements. So all of these conditions are counterbalanced. So sometimes the white face is paired with the negative words. Sometimes the black face is paired with the positive words. Okay, so over time, what they're looking at is a difference in that reaction time. So if you're having more bias, you're going to go through that more quickly. And if you're kind of stopping yourself and raising awareness of your hidden bias, you might slow down a little bit, make more mistakes. And so Project Implicit has been collecting data on thousands and thousands of people. And so over here, this bar chart is an example of what they call the IAT effect, or differences in reaction time. So this is this blue bar on the left is when a white face is paired with positive words. And this is the reaction time for a black face that is paired with those same positive words. And you can see that it takes longer in terms of reaction time for folks on average to respond to that. So this is an illustration of that bias that's detected through the IAT. And Project Implicit has done several of these tests. They've looked at implicit attitudes towards age, weight, race, disability, among others, and find that there's systematic preferences on average that people have for different groups. So this is an illustration of those hidden biases that are these implicit attitudes, and one way to measure them. If we go back to healthcare, hidden bias in healthcare, one group that looked at using the IAT to measure it in healthcare providers, actually Janice, see you then again, you're our model person here because you're an expert in this area, was part of this study that, had healthcare providers take the IAT to measure their implicit racial bias. And then what they did was they audio taped patient provider visits. And they looked at the kinds of communication that was happening in the interactions between patients and providers. And what they found was that for Black patients who were interacting with a clinician that showed an implicit bias or a favoritism for white over Black patients, they found that these were associated with that those Black patients had poor visit communication. So for example, their providers were more verbally dominant. They were not allowed to talk as much. They had less positive affect, meaning they were less affiliative. There was less friendly interactions. And also there was less patient-centered dialogue. We also know from this work that they had, these patients also had a poor quality of interpersonal care. So again, we see in this work, there was less trust and less confidence in healthcare providers, as well as those Black patients felt less respect perceived from that provider who carried those implicit biases. So these are real things that are happening, and we can measure them with tools like IAT, and they surface in the communication and interactions between patients and providers. So in our work, moving forward, we are looking at how we might take a study, an approach like this, and use informatics approaches to dig into this. So what we're doing over the next 5 years in our project is to look at, can we automatically assess these communication cues? Things like head nodding, which is a cue to a friendly, affiliative interaction. Can we look at interruptions? Can we look at speaking time? Can we look at someone leaning forward with interest? Can we sense these kinds of things in a patient-provider interaction in a reliable way to be able to understand a little bit more about those cues that Janice and her group found when they looked at patient-provider interactions? And then if we can do that, can we then design reflective feedback, meaning can we show patients and providers feedback about those cues that we've detected? And then if we bring those pieces together, an automated system that automatically detects these cues to hidden bias and some feedback to patients and providers about what they might do and really try to raise awareness of those implicit attitudes, can we make that hidden bias visible and test that in real life clinical interactions? This is kind of an outline of our 5-year approach in one quick slide. But before I jump into the details there, I wanted to share a little bit about our prior work, because there's quite a bit of prior work that our 2 teams and our 2 sites have done that we're going to be leveraging in our ongoing work. So the first work was work that I did with a graduate student, Rupa Patel, a few years ago, and Mary Zerwinski and Wanda and others, called Entendre. And this was a visual or a design concept, really, about if we had a system that could detect these kinds of nonverbal cues about patient-centered communication. We weren't even at the time looking at hidden bias. We were just wanting to see, is there signs of empathy? Is there gesture? Is there mimicry? Are there signs that the conversation is going well? And vice versa, are there opportunities to let the clinician know that they could be more empathic? So that's our work on Entendre, where we explored some different ways of providing that visual feedback to healthcare providers. At the same time, we explored the literature to look at what are the range of nonverbal cues that we could look at. So we looked at the literature and looked at nonverbal cues associated with positive outcomes from patient-provider interactions when visits ended and the patient felt like there was a lot of rapport, there was a lot of trust. What did the literature say about the nonverbal communication cues that were present, and how was that interaction? So we built what we call a relational communication framework based on that. And then we thought, gosh, wouldn't it be great if someone could, knew, because we're not computer scientists, well, at least I'm not. Wanda has some engineering background, but wouldn't it be wonderful if we could find a partner that knew how to do this sensing? We've got our list of communication cues to go after. We've got some visual design, and we discovered Nadir Weibel and his team down at UCSD. Who we're collaborating with. They did this work called Lab in a Box, which is a multimodal sensing platform that they were able to outfit, an exam room and be able to really sense what's happening in patient-provider interaction, kind of in the wild. And so I'll talk a little bit more about each of these pieces of work so you can see how they build and support our project going forward. So I wanted to play a short video. Actually, how do I? About Entendre.
Clinicians' nonverbal communication skill can make a big difference to patients. Our Entendre system records the interactions of patients and clinicians and provides visual feedback for clinicians. Clinicians can choose to adjust their nonverbal cues in response to the feedback, which could result in patients feeling less anxious, trusting their clinicians more, and potentially having better treatment results. How does Entendre work? Nonverbal cues are picked up from live audio and video streams. Nonverbal cue sequences from the video are assigned relative weights of control and affiliation. Control and affiliation are core dimensions of interpersonal communication. The control dimension ranges from submissive to dominant. while the affiliation dimension ranges from hostile to friendly. We are currently exploring different visual feedback designs that display levels of control and affiliation. One feedback idea comes in the form of a lotus flower. As a new pair of petals forms, the petal size adjusts in real time based on the individual's level of conversational control. The petal color also changes depending on the affiliation of the individual. Here, the petals change from a cool blue to a neutral gray to a warm orange as the clinician's affiliation level increases. Each pair of petals reveals information about nonverbal signals during 1 minute of conversation, and the entire flower represents the last 5 minutes of conversation. We are further examining the use of entendre with clinicians and patients in an actual clinical setting with various designs.
So that was our first piece of prior work on the entendre system, where we're looking at how do we design visual feedback for providers. And that was all a Wizard of Oz. Are you familiar with Wizard of Oz? Kind of being able to manually adjust a system like this to give people kind of the look and feel. So we tested it in a Wizard of Oz type of setting. So we didn't really have an underlying system, but wanted to bring this design concept to healthcare providers and see, would you be interested in interacting with something like this? And they were very, very interested. And so we knew that we had an interesting idea here. And I won't play that again. And so we thought, well, gosh, for that design concept, we were manually entering these kinds of cues that we saw in real time into a system to adjust these visual displays. And we iterated on many different kinds of visual displays. So you could see how scalability of something like this could be really quite difficult. And so it was one of the things that we were really interested in, was looking at how might we use machine learning and some computational approaches to be able to pick up and learn about these kinds of signals in a more automated fashion. And so that was what really drew us to Nadir's work, and so happy to be collaborating with him. Let me talk a little bit about our relational communication framework as well. This is where we stepped back and reviewed the literature, looking at what does the literature say about positive and negative outcomes from care. Things like rapport, patients' reports of rapport, trust, the quality of care, and then looking at the literature that really explored what nonverbal cues were in those visits. All these kinds of nonverbal cues that Rupa, my colleague in the last video, talked about, and how do they map then to some of these outcomes of affiliation and control, that kind of friendly, warm, empathic, affiliative interactions versus that more conversational control where a clinician is dominating the interaction. And what we found were 103 different nonverbal cues. I have a sampling here showing in green boxes the kinds of things that are associated with positive outcomes of care, and the red boxes are unfavorable outcomes, when things didn't go so well. And we categorize them in terms of haptics, things like self-touch. This can be a positive kind of affiliative sign. Kinesics, body movements, things like head movement, head nodding. Proxemics, how close people are. If there's more affiliation, they're typically closer together or turn towards each other, as opposed to the doctor turned towards the electronic medical record. And vocalics, which are vocal cues, things like pitch, interruptions, talk time. And so I won't go through all of these, but just to show, this is a sampling. We have a bunch of different things that we could go after when we're looking at nonverbal cues that map to affiliation and control. And some of them are quite, you might identify with these, maybe entering the healthcare system, things like when a provider is more vocally active than, say, you as a patient. This is a strong finding in the literature. In fact, there's a term called clinical hypocompetence that describes when that happens. And this means that the interactions are less affiliative, they're more hostile, they're less friendly, and the clinician is more dominating, has more control. So those are, this is kind of a interactions have unfavorable outcomes. Patients don't do as well, don't walk away with a good experience. In comparison, things like coordinated speech, balanced talk time when the patient's talking just as much as the provider, turn taking, matched speech latency, so there's some mimicry happening, and vocal back channeling, which is kind of like that, when someone's listening to you, they kind of do that back channeling. All of these things were associated with positive outcomes, where the interaction was more affiliative, more friendly, and the patient felt like they had some control. The doctor was less domineering. So some of these are quite intuitive, and you may have experienced providers with these kinds of interactions. But sometimes some of these kinds of nonverbal cues are quite nuanced. Things like smiling. So a pleasant smile, we all recognize that as being an affiliative signal when things are friendly. But when you see a wide open smile, sometimes we call that panache. Sometimes that's associated with someone who has authority, someone who's a dominant figure. And that puts you into a submissive kind of a stance, or if you're the authoritative one, it makes you more dominant. An appeasing smile, we see this a lot in animal behavior, right, is a sign of submission. Lack of smiling or an angry face, again, this is less affiliative. So not all of these nonverbal cues are super straightforward. Some of them are quite nuanced, and this is where bringing in machine learning and some of these techniques where we're not manually coding is really a great opportunity. And that's where a lab in the box comes in. This is our work, our colleagues down at UCSD, their work, where they have a multimodal sensing platform that they've deployed in patient-provider interactions called Lab in a Box. It uses things like eye tracking, it uses a Connect for body tracking, and uses microphones to determine who's talking and how much. This is an example. You can kind of see it set up in the doctor's office. They collected a whole bunch of data a few years ago down at UCSD at the medical center, as well as at the VA down there. And we think of it as a social signal processing toolkit, right? So social signals are these signals that happen in the interaction and communication between two people when they're interacting. And so we call that SSP in our work. So you'll see that as I'm describing the work moving forward, the social signal processing. It's really just signal processing of a social environment using these kinds of sensors like Lab in the Box uses. And it accelerates the analysis of things like vocal expression and speech, visual attention. So the eye tracker, is there a mutual gaze happening? Or are people looking past one another or not even at one another? What are the body movements? Are there head nods going on? Is there forward leans showing that someone's engaged? And so that's some really exciting work. I wanted to show an example of how the Connect is working because I thought it was really quite interesting. The woman on the left is the image. On the right, you can see in purple the estimation of the joints, and that's how they estimate movement, right? These body movements. The yellow is estimation of gaze. Right, and so there's some magic that's happening down at UCSD, and we're so happy that to have our collaborators to be able to lead this work on the social signal processing piece of our work using their technology Lab in a Box. And what's really cool about this technology is they're able to integrate these multimodal sensors, so sensors coming from various aspects, say in a room, and to be able to integrate this into this data into a place where someone can really understand and look at that interaction. Now, our job is to take all of those streams and try to come up with a way to provide that feedback and understand what that means for providers and patients to become more aware of hidden biases. So that's some of our prior work and I'll talk a little bit about our future work moving forward and how we're going to be leveraging that. So in one, we're going to be using a social signal processing approach to automatically assess these kinds of nonverbal communication cues. And my colleague Nadir Weibel is going to be leading that work. And then we're going to be collaborating with patients and providers to design some reflective feedback using human-centered design. And then Aim 3, we're going to be doing some testing in both simulated and clinic environments to look at the efficacy of a tool like this. So building an SSP model, how are we going to do that? We're going to look and explore what kinds of signals in patient-provider interactions are associated with hidden bias. We're going to be training a classifier to be able to assess these hidden biases in the interactions. And we're really lucky to have some existing data sets. We have 140 patient visits that Nadir and his team have already collected that we can begin to explore using the Lab in a Box data set. We also have 1,280 patient visits that were collected in primary care and de-identified here at University of Washington that were collected using audio recordings. So we can also get some additional insights from that. So we're going to start there and explore some of these communication cues. We're going to then collect a new cohort of data, a new cohort of patient-provider interactions to provide additional data. And in that, we're going to try to oversample for low-income, racially diverse folks that are more likely to experience hidden bias, make sure that we are seeing that outcome that we're looking for. There's a few details on how we're going to train our classifier that I think I might skip through because I want to make sure there's enough time for questions. But we're basically going to be exploring some of the nonverbal cues that came out of our prior work. And then we're going to be using, labeling our data from visits using things like the IAT. We're going to have some other kinds of outcome measures as well, because we recognize this is going to be really challenging. So we're also going to look at explicit reports of bias as well as other kinds of outcomes. Did the patient feel did they feel that they trusted their clinician? Did they feel the rapport was good? Were they satisfied with their care? We'll also be looking at some of those outcomes that are important as well. Aim 2, we're going to be using human-centered design to look at how we can design feedback and collaboration with both patients and providers. We're interested in things, design dimensions like the context of use. Do we do this in training for doctors that are learning how to become practicing physicians? Do we target patients as well as providers, or just focus on providers? Where in the workflow should we do this? Should we do this during during an exam when there's 100 other things going on, or should we do it after the visit so that providers and patients can kind of reflect on that experience? And how should we present this information? So if you think back to our lotus flower in our prior work, that was a descriptive type of presentation. We were just showing what was happening with the growth of the flower. Should we be more prescriptive and say, hey, patient, it's time for you to take a stand and engage in that conversation? So we're going to be looking at these kinds of dimensions in our human-centered design that has 3 parts. We're going to begin with a needs assessment, and throughout this process, we're actually going to engage both patients and providers in primary care. That's going to be our context. And again, we're going to be really seeking out folks that are more likely to experience these biases, low-income, racially diverse folks. For our needs assessment, we're going to be conducting interviews with patients and providers. We're going to ask them about critical incidents, or when they or people that they know have experienced hidden bias in healthcare and what that was like. So we want to learn a little bit more about that experience. And then we're going to show them storyboards to illustrate our design concept as a way to get some additional input into our design. The next step that we're going to do is participatory design with patients and providers. So we'll be holding design groups, and we're going to be asking them to create paper prototypes of different kinds of feedback displays. We might learn about some new things that we don't have yet on our radar that might be interesting prototypes that meet the needs of patients and providers. And then from those prototypes, we're going to select a few of the examples that we think are probably going to be the most feasible, and do some cognitive walkthroughs to understand, to do some testing in terms of how respectful, how constructive, how timely do patients and providers feel that feedback is. And then we'll be iteratively refining those. So that's the work of aim 2. in a quick nutshell. And then our final aim 3, which will be further down along the line in probably years 4 and 5, we're going to be looking at whether or not if we brought these two pieces of our tool together, both the automated assessment with the visual feedback, can we raise awareness of hidden bias? So we're going to be, again, building our tool, bringing those two pieces together. We'll be doing some systematic lab testing. So we'll be doing some simulations with standardized patients. So patients that are Black, patients that are white, patients with different characteristics. And we're going to be using some scenarios after we test healthcare providers with the IAT to see if we can bring out some of those biases and see if we can measure them on our with our tool in kind of a safe environment with a patient actor. And then once we've kind of demonstrated that tool can work in a lab setting, then we want to do a clinic deployment really to look at how the implementation works. So this is a lot of work once you take a tool like this out into the real world where there's ambient light and ambient speech and all kinds of craziness going on. And so we're really going to be doing a pre-post comparison where we have a month where we've got the automated assessment going on, but no feedback. Then we'll add the feedback to see, does that raise awareness of bias? Maybe it does, we're hoping, but I think we're going to learn a ton about how to implement this kind of technology as well as just seeing if it raises bias awareness. So we hope that this work will set us up for our ongoing work in the future after 5 years to do even more work in clinical environments. So at the end of the day, these are our anticipated contributions. We will be working towards building a social signal processing model that links patient-provider interactions with hidden bias. We're going to be designing reflective feedback in collaboration with both patients and providers. And we believe that by testing this in both simulated and real life contexts, that we're going to learn quite a bit about hidden bias in healthcare and how we might address it to improve the quality of care and reduce healthcare disparities. We're also really excited about the possibility of using what we learn to ground future studies where we can look at additional populations, folks from the LGBTQ+ community in particular. So in conclusion, hidden bias is a major problem. It's not fair, and we want to do something about it. And so we hope that through this work, we can raise awareness about health disparities and the problem of hidden bias that contributes to it. Existing solutions are great, they're educational, but they are disconnected from that real life delivery of healthcare, that real life experience. So we want to look at ways to use informatics and computer science in order to do some innovative work. And our approach, we feel, is innovative and has potential to not only provide practical insights for training and healthcare delivery, but also advance research at the intersection of human-computer interaction, health informatics, as well as computer science. And most of all, we want to raise awareness about this problem of implicit bias and ultimately help to address healthcare disparities. So with that, I want to thank you for your time. I have a few minutes for questions. Thank you. Yes.
Thank you very much for your talk. This is really exciting work. Thank you for sharing it with us.
Yeah,
and I really appreciate the example of smiles and the complexity of that. And I'm wondering what kind of controls you have for invisible characteristics, for example, neurodiversity and country of origin, in looking at these motions.
Good question. So we've talked a little bit about this, and we recognize this is a really complex, nuanced problem that we're running into. So we actually decided that we're going to step back and start with native English speakers, for example, because we know that that is going to simplify the problem as a first step. Not that it's not important to look at the richness of all, and the complexity and nuance, but that's how we've decided to go about follow it.
Okay, I mean, I can't wait to find further things as well, but even a native
Yeah.
English speaker does not necessarily do country of origin, right?
Tell me what you mean.
Well, English people.
Well, native English speakers, well, we could probably, I guess what we mean by that is folks that grew up speaking English from the US. Yeah, thank you though. But definitely in future work, and we could take a look at what the literature says as well. But it's a important issue because there are cultural differences, even in native English speakers who are born in the US. There are cultural differences in how people speak. So definitely a problem. Yes. Yeah.
Make sure that you press on the yellow circle.
It works now. Thank you so much for your talk. Fascinating work.
Thanks. Yeah.
So I've seen a lot of similar work, but not in a clinical setting, more in like algorithmic bias and machine learning. I was curious, like, because you're testing this in the wild, if you could talk a little bit about, you said you're going to learn a lot with your first deployments. If you could talk a little bit about how do you try to minimize risk? And how does your work relate to a lot of research that has been done related to bias in VR? So there's a series of studies that were kind of trying to put people in VR in a different body or in a different setting. I don't know if you know about it.
No, I'd love to learn
We
more.
can talk more about it.
Yeah, for sure.
But yeah, how would you minimize risk when you do these deployments in the wild? Thank you.
Sure, that's a great question. So you have to be really, really careful. It's something that our team talked about, with clinicians on the one side. This can be it cannot feel so good. If you take a test and you find out that you're carrying these attitudes that maybe you didn't know you were carrying. So it's important. And on the patient side too, making sure that they're ready, to be able to engage in this kind of technology. So the clinical deployment in our AIM-3, that it's a very, very small part of the grant, and it's at the very, very end. And so our approach to that is to start small. We're going to partner with, and I was a little rushed there, so I had to skip through some of the details, but we're going to partner with up to 4 clinics and 1 clinician in each of those. So we're going to take a very small chunk and try to work through some of those details and make sure that these are the clinicians may be interested and self-select into this. So we may get less in terms of a hard outcome on how we change, raised awareness of bias, but learn more about how to appropriately go about doing this. We're not going to do a universal testing. We're going to, of course, allow people to turn off this technology even in a clinical deployment that their clinician is engaged in the research if they don't want to participate. So all the usual human subjects types of practices. But I think we're going to learn a lot about how to go about doing this, and we're going to have some surprises about how people respond. So it's a great question. I'd love to learn more about the VR work. So thanks. Yes.
Yeah, so I just have a broad question. Since you mentioned that one of your main goals is to raise awareness of hidden biases in healthcare providing, but the report you mentioned is almost 20 years old. And so I guess I'm just curious as to what exactly is going to be done differently if that report and patient feedback hasn't kind of already accomplished this.
Yeah, it's really surprising that we're still seeing the same continued issues. So the educational programs are great, but we need something more. And I don't know that our approach alone is going to do, raise awareness and change behavior. But I think exploring new opportunities using technology is definitely an opportunity to try to attack this, because if we don't do anything, it's going to continue to perpetuate. As I showed in the medical algorithms, we're starting to see these biases enter in. So it's a sign that it's a continued problem, that we need some smart people to take, like all of you, to take a look at these problems and come up with innovations. Yes. Can you hear? Yeah.
I'm wondering about whether you'll have the opportunity or ability to actually discern interacting factors of any kind. So you can kind of imagine people leaning forward, might be gender related as to what that, what kind of impact that really has. But then also, you know, I didn't see much that was happening with actual speech or what's being stated, but leaning forward and making a certain kind of statement relative to not saying anything, or some other kind of statement I can imagine would be, you know, again, have very different impacts on the patient, for instance. So I didn't know how you tease all that out, or if it's even possible.
Yeah, it's a good question. We're not sure either, and that's why we want to do this work, is to take a look at some of, so the literature does tell us that there are certain kinds of nonverbal communication cues that are associated with these signals of affiliation and control. So I think the first place to look is take a look at, do we see any of those? Do we see a high prevalence of those? And then if we have an IAT test, for example, we have some measure of bias on the clinician side. Are we seeing differences between providers that have a more bias, say more racial bias, than other clinicians? Do we see a difference over many, many interactions with different patients? Do we see differences? So it's a real challenge that we're up against. And I don't think we're going to be able to, in this first pass, tease out all of the interactions and nuances. But we're hoping that we're going to be able to, if we can label these visits with an IAT, a set of IATs, look and see if we can discern differences in the kinds of nonverbal communication patterns, the ones that we see, especially in the literature, that that matter to patient outcomes.
Great, thank you. Let me take one more, maybe.
Sure.
Hi. So as researchers conducting research on bias, how do you try and prevent bias from within your group, or how do you, from multiple angles, like cultural and then also just interpretation of the data, what are ways that you all work to do that?
Good question. And it's something that we've been talking about on our team. Do we have the right makeup to be able to have experience with these kinds of things? And so part of it is looking at our advisory board and bringing on, for example, we're going to be bringing on patient advocates who come from the communities that we're trying to better understand, so that we can bring in that that perspective. Because, you know, as much as we want to be empathic and understand, there's certain biases that I'm going to experience as a woman, for example, but there's certain biases that I'm not going to experience. I'm not going to have that same insight that someone that's coming from those communities is going to have. So that's one way in our advisory board, is bringing in people beyond our team that have direct experience, and that we can say, here's what we're learning. How does this sound to you? How would you approach this? So I think that our team's very collaborative and are looking for those kinds of connections. And right now we're at the beginning of our project and seeking out those partners to help us navigate this. Great question, it's super important.
Great, I think we have to close up. We look forward to hearing about your results maybe in a couple of years when you've made some progress. So thank you very much, Andrea.
Thanks. Thank you.